Hello and thank you for listening. My name is Michelle. I'm the current PGY2 Oncology Pharmacy resident at Monument Health, and I'm going to be discussing hypercalcemia of malignancy in this presentation. My presentation objectives for you all are listed here, and I will be using some abbreviations throughout the presentation, so I wanted to include an abbreviation slide for your reference. I wanted to start off the presentation with some general background information. So first, malignancy is the most common cause of hypercalcemia in the inpatient setting, and it occurs in patients with both solid tumors and hematologic malignancies. The most common cancers associated with hypercalcemia in the United States are breast, renal, lung, squamous cell cancers, and multiple myeloma. It is also important to note that hypercalcemia is a poor prognostic factor for oncology patients, and historically about 50% of patients died within 30 days of presentation, but survival rates have improved with the use of bisphosphonates now. I also wanted to mention that hypercalcemia can be a presenting feature, but it typically occurs in patients with an already established oncology diagnosis. Next, I'm going to go through some pathophysiology for hypercalcemia of malignancy. This pathophysiology is divided into 4 different categories. First, we have humoral or tumor secretion of parathyroid hormone-related protein. Second, we have osteolytic hypercalcemia. We also have tumor production of calcitriol. And then lastly, we have ectopic tumoral secretion of parathyroid hormone, and I'll go through each of these more in depth in the coming slides. First, I will be going over humoral hypercalcemia, which is often mediated by secretion of parathyroid hormone-related protein by the tumor. This specific pathophysiology accounts for about 80% of all cases of hypercalcemia of malignancy, so it is our most common pathophysiology for hypercalcemia of malignancy. The cancer types this pathophysiology is mainly seen in is mainly solid tumors and some lymphomas. To the right here, you can see a visual representation of this mechanism. What happens is the solid tumor releases parathyroid hormone-related protein, which stimulates excess bone resorption and release of calcium free from the bone matrix, and that in turn weakens the bone structure and elevates the circulating calcium. This also stimulates increased renal reabsorption of the calcium, and that further increases serum calcium levels. The second most likely pathophysiology for hypercalcemia of malignancy that I'm going to discuss today is osteolytic hypercalcemia. This specific pathophysiology occurs in about 20% of all cases, and it's more common especially with multiple myeloma and maybe our breast carcinoma. The mechanism of this pathophysiology is that it results from increased osteoclastic bone resorption, and you can see a visual representation of this to the right, but what happens is the tumors produce many factors that stimulate osteoclast production and action locally, and that in turn leads to increased skeletal resorption and hypercalcemia. The remaining 2 pathophysiology categories for hypercalcemia of malignancy are much less common in general. These cases of hypercalcemia, which are again mediated by either calcitriol or parathyroid hormone, account for less than 1% of cases. So again, very small number of cases. The mechanisms are listed here, but we have our calcitriol secreting lymphomas that result in a combination of enhanced osteoclastic bone resorption and enhanced intestinal absorption of calcium. Or we have our ectopic PTH secretion that's generally a result of DNA amplification and rearrangements that cause high PTH mRNA expression and lead to parathyroid hormone overexpression and high levels of calcium in the blood by increased skeletal release of calcium. It is important to know that our calcitriol secreting lymphomas and those patients with hypercalcemia of malignancy caused by this calcitriol-specific pathophysiology is going to be treated a little bit differently than the general overview of treatment and how that's applied for our typical cases with the other pathophysiology. Treatment for those mediated by the calcitriol pathophysiology is generally steroids, and I'll briefly mention that in our treatment section as well, but I wanted to point that out here. Next, I wanted to mention some of the symptoms that our patients with hypercalcemia of malignancy might more frequently experience. I also wanted to point out that the severity of symptoms relates to the level of calcium in general and how quickly the level of calcium rises. And it is important to note that the symptoms are typically nonspecific, but hypercalcemia can lead to progressive decline, including renal failure and coma, so it's important to address this right away or as quickly as we can. To the right here are quite a few of the more common nonspecific symptoms that patients might have, such as lethargy, constipation, nausea, confusion, polyuria, weakness, acute renal failure. Everything listed there are possible. A good acronym that a lot of people mention when talking about symptoms for hypercalcemia of malignancy as well is bones, stones, moans, and groans, if that helps you remember. In regard to diagnosis, there are a couple different calcium lab draws we may see. The more common one to see in practice is called corrected calcium, and this is the total serum calcium corrected for the albumin level as in the equation here. This can be read to determine the classification of hypercalcemia as either mild, moderate, or severe if it's above normal. And really mild would be anything from 10.5 to 12, moderate would be from 12 to 14, and severe would be greater than 14 for the corrected calcium. The other type of calcium lab that can be used for classifying hypercalcemia is called the ionized serum calcium, which is actually a little bit more accurate than the corrected calcium. It's a better measurement when it's done correctly as it's more sensitive, and the corrected calcium is more of an estimation. But we don't really do this ionized serum calcium as much in practice. I'm not really sure why, but we usually do the corrected calcium more frequently. And this classification is broken down similarly as the corrected calcium was on the previous slide, just with different levels, as the normal range is a little bit lower for ionized serum calcium. Mild hypercalcemia would be 5.6 to 8, moderate hypercalcemia would be 8 to 10, and severe hypercalcemia would be greater than 10 milligram per deciliter for an ionized serum calcium. Now I'm going to move into the bulk of my presentation, which is going to focus on the treatment of hypercalcemia of malignancy, and I'm going to start out on the next slide with a patient case to walk us through a real-life example of this hypercalcemia of malignancy and treatment of it. So here is the patient case I'm going to walk through and present to you today. So we have NK. He's a 63-year-old male who presented to the emergency department with significant confusion and lethargy. He also reported not having a bowel movement for several days, so he has quite a few symptoms of hypercalcemia of malignancy. His labs are notable for serum calcium of 15.6 milligrams per deciliter, serum creatinine of 3.1 milligrams per deciliter, and albumin of 3.4 grams per deciliter, so definitely showing signs of hypercalcemia of malignancy all across the board. Along with aggressive IV hydration, which of the following initial interventions would be most appropriate for our patient NK? So there are a lot of treatment options listed here, and I'll let you look through them for now, but we're going to go through our treatment options for this and then revisit our case with an answer after our treatment options. So I want you to just look at this and think this through as we go through our options. First things first, it's important to note that when we have symptomatic hypercalcemia, this is an oncologic emergency, so we need to start treatment as quickly as we can. Patients are generally hypovolemic when they present with hypercalcemia of malignancy, so hydration is one of the first steps for management of this hypercalcemia. There are a lot of different recommendations for fluid and what rate we should give patients, and a bolus based on the individual patient and specific reference. But really, the general gist of that is to give some sort of bolus and then maintain a urine output of 100 to 150 milliliters per hour, somewhere around there. Our specific oncology pharmacist training materials that I've referenced list this bolus IV fluids of 500 to 1,000 milliliters per hour for the first hour, then reduce to maintain a urine output of 100 to 150 mils per hour until patient is euvolemic as the fluid rate. Along with starting hydration right away, we would also want to be sure to discontinue any offending agents that could potentially be contributing to increased calcium, such as any calcium supplements the patient may be taking, thiazide diuretics, vitamin D, things like that. Another possible option that really isn't used as much anymore, but it is still a possible option, is loop diuretics, and as mentioned, the use of this really is no longer recommended, but they are still listed as possible options. And really, if you use this, it would be probably furosemide. This could increase urinary excretion of calcium, but if we did do this, it would especially need to be avoided until euvolemia, as if there were any hypovolemia from decreased renal perfusion, that would reduce the renal excretion of calcium further. Another thing to note is treatment of the malignancy itself can also help resolve the hypercalcemia. Other very important treatment options for hypercalcemia of malignancy are our bisphosphonates and the rank L inhibitor denosumab. I'll be going over these individually and getting into more specifics in the coming slides. Starting out with our bisphosphonates, we have two main options, and those are zoledronic acid or pamindronate. These work by reducing osteoclastic bone resorption, and the onset of action of these products is around 2 to 4 days. Typically, this naters in around 4 to 7 days, so we can consider retreatment after 7 days, but generally not before. This is really kind of one of our most effective therapies for hypercalcemia of malignancy. So as I mentioned, one of our very important treatments for this hypercalcemia of malignancy. There are a few adverse effects I wanted to pull out, such as bone pain, ocular inflammation, electrolyte abnormalities, and a big one being warning for osteonecrosis of the jaw. Really, osteonecrosis of the jaw is lower in incidence initially, maybe even less than 1%, but the longer a patient's receiving treatment, it does increase. And if a patient has poor dental health or dental procedures, that increases their risk of this as well. I'm going to continue talking about our bisphosphonates, zoledronic acid, and pamindronate in the coming slides. I'm going to talk more about zoledronic acid or Zometa first. This zoledronic acid is specifically our preferred bisphosphonate for hypercalcemia of malignancy. The recommended dose of zoledronic acid is 4 milligrams IV over 15 minutes, and it is important to note that there is no renal dose adjustment necessary for hypercalcemia of malignancy, specifically when serum creatinine is less than 4.5 milligram per deciliter. For serum creatinine greater than 4.5 milligram per deciliter, the use isn't recommended unless the benefits seem to outweigh the risk, as these patients were excluded from clinical trials, and the recommendation is to really consider an alternative agent when possible. I also listed the cost per milliliter of the zoledronic acid on this slide for the 4 milligram per 100 milliliters, and this is the wholesale acquisition cost just for comparison to the pamindronate cost on the next slide. Per mil, this was about 72 cents to $2.16. Next, I wanted to talk just a little bit more about pamindronate dosing and show you the cost of that per mil. So pamindronate is dosed anywhere from 60 to 90 milligrams IV over 2 to 24 hours. That's the recommended range. And the cost per mil for the pamindronate in wholesale acquisition costs that I found for the 6 milligram per mil strength was about $4.09. Now I'm going to move on to discuss some study data over zoledronic acid versus pamindronate in the treatment of hypercalcemia of malignancy, and this should help us understand medication place in therapy. So this specific study was the only head-to-head study done at this time that compared zoledronic acid versus pamindronate, and still done that I know of. And it was a pooled analysis of two identical concurrent multi-center randomized double-blind trials that were conducted at centers in the United States, Canada, and Europe and Australia. The purpose of this study overall was to compare the efficacy and safety of zoledronic acid and pamindronate for treating hypercalcemia of malignancy. Patients were included in this study if they were adults with histologic or cytologic confirmation of cancer and hypercalcemia of malignancy, and for this they used a baseline corrected serum calcium of 12 mg per deciliter or more. The study had a lot of listed exclusion criteria, some of which I have listed here. The main exclusion criteria that I wanted to pull out, because it does fall into our place in therapy of treatment options, is that patients with serum creatinine more than 4.5 mg per deciliter were excluded from this study as mentioned. For the study treatment, patients were randomized to be treated with either a single dose of zoledronic acid of either 4 or 8 mg via 5-minute infusion, or pamindronate 90 mg via a 2-hour infusion. Bisphosphonate therapy was also given simultaneously with IV hydration, so that helped with some of the blinding in the study. And patients that were refractory to initial therapy or who relapsed up to 56 days after the initial treatment were retreated with a single dose of the 8 mg zoledronic acid. Listed here are the study endpoints. The main endpoint was patients evaluated for complete response, defined as normalization of corrected serum calcium to 10.8 mg per deciliter or less by day 10. They also looked at the time to relapse of hypercalcemia of malignancy, duration of response, efficacy of retreatment for relapsed or refractory hypercalcemia of malignancy, and safety and tolerability. For the study population, there was a total of 287 patients that were randomized, and 275 patients ended up being eligible for the efficacy analysis per the protocol. 86 patients were in the zoledronic acid 4 mg group, 90 were in the 8 mg zoledronic acid group, and 99 patients were in the pamindronate 90 mg group. Overall, the characteristics were pretty well balanced across groups. This slide shows a graphic of the study efficacy endpoint, the primary endpoint, showing the complete responders, mainly at day 10, but it also shows day 4 and day 7. You can see that the mean corrected serum calcium levels at day 4, 7, and 10 were significantly lower in the patients treated with 4 or 8 mg of zoledronic acid than in patients treated with 90 mg of pamindronate. And in the primary 10-day analysis, 88.4% and 86.7% of patients in the 4 and 8 mg zoledronic acid groups achieved a complete response compared to 69.7% of patients in the pamindronate 90 mg group. However, it is also important to note there was really no significant difference in the proportions of patients with complete responses between zoledronic acid 4 and 8 mg dose groups. So really the 4 mg dose was just as good as the higher dose. With regard to the safety analysis of the study, the most common adverse effects that were seen were fever, anemia, nausea, constipation, and dyspnea, and these occurred with similar frequency among zoledronic acid and pamindronate. There were renal adverse events reported, and they were reported just somewhat more frequently in the zoledronic acid groups than the pamindronate group, but it was pretty similar across the board, and if you look at it, it was really more reported in the zoledronic acid 8 mg compared to the zoledronic acid 4 mg. The conclusion drawn from this study is that IV zoledronic acid, particularly the 4 mg dose, provides a more effective and more convenient treatment for hypercalcemia of malignancy than the pamindronate, while maintaining a similar safety profile. Another caveat to note, just to piggyback on that, is that zoledronic acid is also cheaper than pamindronate. Now I'm going to briefly discuss our rank L inhibitor, denosumab. This medication is dosed 120 milligrams sub-Q weekly for 3 doses during the first month and then every 4 weeks after that. And it's indicated for hypercalcemia of malignancy that's specifically refractory to bisphosphonate. So we would use this after essentially failing a bisphosphonate. And the onset of this medication is around 2 to 4 days. Another treatment we have as an option is calcitonin. This medication is dosed 4 to 8 units per kilogram, sub-Q or IM, every 6 to 12 hours. It is very important to remember that for hypercalcemia of malignancy, this should not be given intranasally, and it can be considered in a place in therapy as an alternate or adjunct to aggressive hydration and bisphosphonates for symptomatic hypercalcemia. How this medication works is it directly inhibits osteoclastic bone resorption and promotes the renal excretion of calcium by decreasing tubular reabsorption. And this can reduce calcium concentrations about 1 to 2 milligram per deciliter within 4 to 6 hours, but this medication's maximum response is usually within 12 to 24 hours. And this efficacy is limited to especially the first 48 hours with repeated dosing, just due to the development of tachyphylaxis. So it does provide a little bit more rapid reduction of calcium than bisphosphonates, so it can be used with a bisphosphonate if a patient is symptomatic, but it really isn't something that we would use for more long term. Another treatment option we have that should only be used in patients with tumors that produce that calcitriol are glucocorticoids, and these work by inhibiting the conversion of vitamin D to the calcitriol, so that makes sense as to why they should only be used with that pathophysiology. They could also maybe have a role for patients with lymphoma and elevated vitamin D levels. And really an example of this would be prednisone 20 to 60 milligram per day for 10 days. That could reduce the serum calcium concentration within about 2 to 5 days, or we could do IV hydrocortisone 200 milligrams daily times 3 days. With this, you'll also need to be careful to watch for tumor lysis syndrome in these patients that are undergoing treatment with steroids. Here are the final couple treatment options I'm going to discuss today. The first one is a calcimimetic, such as calcinet. These could be effective for parathyroid carcinoma or primary or secondary hyperparathyroidism. And then we also have the option of dialysis. This could be considered in the setting of very severe hypercalcemia and renal insufficiency if we're unable to hydrate the patient. So that brings us back to our patient case, our patient NK again, who's having those symptoms of hypercalcemia of malignancy and has very high serum calcium, needs another treatment option along with that aggressive hydration. And the correct answer is zoledronic acid 4 milligram IV once with calcitonin, and that is given sub-Q every 12 hours. This is because bisphosphonate therapy has been proven to reduce hypercalcemia of malignancy, and the full dose of the zoledronic acid is recommended when used for hypercalcemia of malignancy, with that serum creatinine up to 4.5 milligram per deciliter. The patient is symptomatic, so at this point we would want to consider use of that calcitonin sub-Q or IM, and again not intranasally, to provide a more rapid reduction in the calcium before the effect of the bisphosphonate therapy in about 48 to 96 hours. Please let me know if I can help address any questions. And here are the references I used for this presentation.